Today's episode is an interview with Dr. Bruce Berger. Dr. Berger uses his voice to educate healthcare providers about motivational interviewing. If you know someone who is ambivalent or resistant to behavior change, you will learn something from Dr. Berger. You're listening to the Pharmacist Voice Podcast, a journey-style podcast about my career change from pharmacist to voice actor. I'm your host, Kim Newlove. I alternate solo shows and interview shows. The solo shows are about my career change, and the interview shows feature a variety of people who use their voices to advocate, educate, or entertain. I specialize in medical narration and e-learning. To hire me, visit thepharmacistvoice.com. Thank you for joining me for episode 13. First, I'll give you some background information on my guest, Dr. Bruce Berger. Then I'll share our interview, which was recorded on Sunday, March 22, 2020. Bruce is President of Berger Consulting, LLC and Emeritus Professor at Auburn University. He has developed COMMIT, Comprehensive Motivational Interviewing Training for Healthcare Providers. He has taught motivational interviewing in healthcare and methods for improving treatment adherence for over 30 years. Bruce received his BS in Pharmacy and Masters and Ph.D. in Social and Behavioral Pharmacy from The Ohio State University. He taught at West Virginia University in 1980 and 1981. After 2 years at WVU, Bruce moved to Auburn University and taught there until his retirement from the university in September of 2009. His research interests included health behavior change and improving treatment adherence. He has written or presented over 800 papers or seminars on these topics. Bruce has been a consultant and trainer for numerous pharmaceutical companies and health plans, and he is the recipient of numerous awards, including the 2007 APHA Wiederholt Prize for the best research publication in the social, behavioral, and administrative sciences in pharmacy. Bruce is also the 2009 recipient of the American Association of Colleges of Pharmacy's Robert Chalmers Distinguished Pharmacy Educator Award, one of the association's 3 highest honors. Bruce is author of the book Motivational Interviewing for Healthcare Professionals, A Sensible Approach, 2nd edition, published in 2020, and an 8-hour accredited motivational interviewing e-learning program for healthcare professionals, published in 2015 along with William A. Villome. Without further ado, here's my interview with Dr. Bruce Berger. Hi, and welcome to the Pharmacist Voice Podcast, Dr. Bruce Berger. How are you?
I'm great. How are you, Kim?
Doing great. Great to have you on this podcast. While we're experiencing so much healthcare crisis in our nation, at least we can be productive and get together and get some great information out to folks about motivational interviewing.
I appreciate you asking me.
My pleasure. Can you tell me how you became interested in motivational interviewing?
I had been doing a lot of research on improving adherence to health behaviors, in particular, adherence to medication regimens. And one of my former graduate students, actually named Karen Hudman, who's at Purdue University, had told me about the work of somebody named William Miller. And I started looking at what Miller had done. Miller had developed, back in the 70s, an intervention in clinical psychology to be able to help people who are addicted to substances, and really revolutionized the way they started talking to folks that became addicted to substances. They had been using a lot of what was called tough love, and actually found it didn't work. That so much of substance abuse was shame-based, and tough love made people shame even worse. And Miller started finding that if he really started reflecting back in very respectful ways what people were going through, and then really asking some open-ended questions about, tell me how serious you think this is. What kind of impact do you see it having? Do you think a lot of people are really just overblowing what's going on with you? And doing that in a way that was non-threatening. that he actually got people to really honestly start talking about what was going on. And without going into all the details, so he called it motivational interviewing. It's a little bit of a misnomer because he wasn't trying to motivate people to stop abusing substances. He was trying to explore their motivation to quit. You know, what would have to change? And of course, first thing they had to do is recognize there was a problem. And so he called it motivational interviewing because also, so he wanted to understand their motivations to both use and quit. And it was an interview because what they had to say was as much as important as what he had to say, that it was a meeting of experts. They had an expert on their substance abuse. He was an expert in psychology and how he might be able to help them. When I started reading about this and in fact, I contacted Dr. Miller and we had some great conversations. I just was amazed. And I started thinking, wow, if you could do this, and by the way, his intervention is still today the most successful intervention for substance abuse. And I started thinking, wow, if you could do this intervention and have the lowest rate of relapse of any intervention with substances, surely high blood pressure is nowhere near as daunting, and the behaviors surrounding managing high blood pressure. And so I brought it into pharmacy and healthcare. And when I first brought it in, actually, people were like, you know, what is this? And now everybody knows about motivational interviewing. They don't know about it well, but they've heard about it.
That's a good segue into my next question. For anybody listening who may not be familiar with motivational interviewing, how would you describe it? What exactly is it?
It's a motivational interviewing is made up of a whole bunch of skills, and it's one of the things I like most about it is that it's evidence-based. We know it works. The theories that went into MI, the psychological theories that went into MI, just to name a few, cognitive dissonance theory, positive psychology, were all well-researched, well-tested, evidence-based as having positive impact, especially in psychotherapy. And so what it really is a series and set of skills really to help a healthcare provider in terms of what we're talking about be able to talk to patients who are either ambivalent or resistant to behavior change relative to health behaviors, whether it's taking a medicine, losing weight, changing their eating habits. So they're either, I'm not sure I want to do this, or I definitely don't want to do this. And so it's a series of skills and a method of talking to patients who are ambivalent or resistant about change, about health behaviors, that is non-confrontational, that respects the fact that ultimately this is the patient's decision. And so it combines reflection and addressing patients' issues in order to increase the probability that when we're all done, the patient will be more likely to engage in healthy behaviors.
Great explanation. And you're so passionate about it. I can't help but ask, how long have you been teaching folks about motivational interviewing?
Probably about 30 years. And it's been a real learning process for me also. When I first started teaching it, I kind of went by the book, by the way Miller taught it. And then I started learning that the way Miller taught it was problematic for healthcare. And this is by no means any kind of criticism of Miller. Miller was teaching clinical psychologists. And everything he was doing in teaching clinical psychologists was making the assumptions in clinical psychology, that they had 50 minutes to an hour with each session. They had multiple sessions. And these people already understood what cognitive dissonance was in positive psychology. We had no such background in healthcare. And not only that, we work in time-limited environments where if we have 5 to 15 minutes sometimes, we're lucky, and we may not see the patient again or talk to them. So we had to reformulate MI with that in mind, to help healthcare people who don't have that background in psychology. And so the other thing we found is Miller taught with a whole bunch of acronyms. Anybody that's learned any MI knows these acronyms: READS, ORS, DARN. And what we found in teaching MI to healthcare people is A, they couldn't remember the acronyms. B, if they could remember the acronym, for example, ORS, they might remember ORS, and then they had a hard time remembering, well, what does the O stand for again? And then if they could remember that O stood for open-ended questions, then they had a hard time remembering, okay, when exactly do I use an open-ended question? So we decided we really had to change the way we taught MI. And we went to what is called a sense-making approach. And it got rid of all the acronyms. In fact, we kiddingly call our approach FROMA, free of major acronyms. And our approach basically uses a theory by a communication expert named Brenda Durbin. And what she basically says is human beings are sense makers. As you and I are talking, we're using everything we bring to this experience to make sense of each other. And we cannot not do that. In other words, this is just who we are. So so patients, on the other hand, are making sense of three things. They're making sense of the illness. What does high blood pressure mean to me? They're making sense of the treatment. Does this treatment, given what I believe about this illness, make sense to me? And they're making sense of their relationship with the healthcare professional. And that relationship's critical to whether they want to move forward and whether they even believe any of the things the healthcare professional is telling them. And we found that when we started teaching this sense-making approach, all these people that had learned MI before and really didn't understand it started going, oh my gosh, now I get what I'm supposed to do with MI.
It sounds like you've talked to healthcare professionals other than pharmacists. Can you give me an idea of who your learners are?
Well, my learners do include clinical psychologists. When I used to do a lot of live events in Atlanta every year, people would come from all over the country. And again, the advertisement is we're going to focus on chronic illness management. All the behaviors associated managing diabetes, high blood pressure, high cholesterol, you name it. But we'd had a lot of clinical psychologists show up because, for example, the VA uses a lot of clinical psychologists to teach MI. And so, but they did not have the background, on the other hand, in healthcare to apply MI skills to healthcare situations. So I've taught physicians, pharmacists, nurses, pharmacy technicians, social workers, sociologists, veterinarians, physical therapists, chiropractors, because the skills, or I should say the principles, really don't change just because the behavior might change. In other words, a physical therapist has to go through the same kind of issues, helping patients actually go home and now practice the exercises they were given, as we do when we say to a patient, you got to take this medicine every day.
When we talk about your learners, I understand that recently you were supposed to speak at the annual conference of the American Pharmacists Association. Is that right?
Yes.
Can you tell me a little bit about who your learners were going to be? Was it just pharmacists or also others? Technicians, interns?
Whoever wanted to show up, and I'm not being facetious. I'm saying sometimes I don't know who will be in the audience, but generally speaking at APHA, you can expect pharmacists, probably pharmacy technicians, faculty. I've done one of the groups I left out. I've done a lot of training of faculty in MI so they could go back and teach their students. And so I do happen to know that a number of physicians who actually are members of APHA were going to be there. They told me they would be there. We have a client down in Florida, for example, that's using our e-learning program, which we can talk about in a little bit.
I'd love to, yes.
They're a huge primary care organization that has had almost 400 primary care physicians go through our training. So we have a pretty broad swath of people that want to learn this.
That's a great skill to learn. And if you wouldn't mind, I'd love it if you'd talk a little bit about, for people that want to learn more, what do you have available for learners?
Well, we have the second edition of our book has just come out, and people can buy it on Amazon. It's called Motivational Interviewing for Healthcare Professionals: A Sensible Approach, kind of a play on words with our sense-making approach to MI. And it uses our sense-making approach. It's got 2 new chapters in the second edition, which just came out. And you can go to Amazon and get it, but if you go to APHA's website, and I'm not trying to sell APHA, but if you go to their website, it's less expensive, even if you're not a member. It's a lot more expensive on Amazon.
And it's available in print, not in audiobook, correct?
It's actually available in both as a audiobook. I believe it's available as an ebook also.
Very good.
And in print. And we also have an e-learning program that's 8 hours, and it provides 8 hours of accredited continuing education for nurses, pharmacists, physicians, pharmacy technicians, and social workers. And it's available through Purdue's continuing education website. People have 3 months to complete the program bookmarks, so that during that 3 months, they can go in, do a little bit, come back. When they come back to the program, it'll ask them, do you want to continue where you were, or you want to go back to the beginning of the module? There's 6 modules. And so that gives them 8 hours of accredited CE that they can really do at their own pace. And we have a lot of organizations, including MTM organizations, that are using it to train their pharmacists to talk to patients.
You and I talked once about this being accessible to entire universities. Can you talk a little bit about that?
Yeah, sure. Any university that's interested in the program. Now, as I was saying, we have the program available on Purdue's website. And by the way, there are huge group rate reductions also, starting at 5 people. So individuals can go through the program, but if a group wants to go through the program, they can get a tremendous discount. And a group, in order to reduce their risk, they have 3 years to use their code. So if a group came in and said, we want to put 100 people through the program, they would get a code that they can give out to whoever they want to give it out to. And that code, their code, is good for 3 years. So that gives them time to be able to use the 100 seats, essentially. Now, for schools of pharmacy and schools of nursing, medicine, any university, they can actually subscribe to the e-learning program for $1,000 for a year for unlimited use. And what we do is we actually send them all 6 modules. They put them on their LMS. The modules will expire in a year. If they try to use them after that, they won't work. And they can put it on their LMS and have their students use them. So, for example, Idaho State University is using the e-learning, and doctors Mike Biddle and Rebecca Hoover, instead of them teaching this 8 hours worth of MI material, are now using the 6 modules. And after each student goes through each module, they then use their time to put the students through immersion exercises. So they now directly apply what they've just learned after getting the background information. So they also use this with standardized patients now, et cetera, and they're incorporating it throughout the curriculum. They're about to publish a paper on what they've done, and they actually want a reward for the changes they've been able to show in the acquisition of skills and knowledge of their students based upon the e-learning, which makes me feel really good too. But in any case, so that's how a lot of schools are starting to use it. And the really nice thing is too, when a school spends $1,000 to use the program for a year, unlimited student use. That program can be used by any unit in the university and at no additional cost. They can share it with any department or program in the university for that single fee.
It seems like this is a great time for learners to be using this type of a product because unfortunately, a lot of universities have had to resort to distance learning.
Yep. You would think that would be the case. The biggest barrier we have with schools is them allocating sufficient curricular time to learning MI. Unfortunately, a lot of the schools are not allocating a lot of time to MI, often don't have experts to teach it, which is another reason we put the e-learning out. And you cannot learn MI in 2 hours. You've got to be able to learn all the skills. It's really a different way of talking to patients. And, at some point, I'd love to give you a couple of examples of what we're talking about to help people understand some of the ideas behind MI.
Ooh, there's no time like the present. We can do it now if you want. Can you
Sure.
teach me how to help my husband learn how to put his socks away?
Probably not.
No, I'm just kidding. But yes, please. Yeah, if you want to go through some examples, that'd be wonderful.
Yeah. So when we came up with this sense-making approach, remember I started by saying that MI was originally developed and still is for patients who are either ambivalent or resistant to change. So whether it's ambivalent or resistant to stopping drug abuse, taking a medicine, losing weight, whatever it is, it's about ambivalence and resistance. One of the things that we learned very early on is that when patients are ambivalent or resistant to change, their sense-making about a behavior is often problematic. And the reason it's problematic is that it's either based on inaccurate or incomplete information. Now, let me give you an example of a very common thing that we're all familiar with in healthcare, and then walk you through all that. I'll add one more thing, and then I'll show you how this all works. What we have learned is that a patient's sense leads to a conclusion, which leads to a decision about behavior. All right, so let me give you an example that pulls this together. Any of us that have practiced pharmacy or healthcare have heard patients with high blood pressure say, I don't know why I need this medicine, I feel fine. Right?
Definitely.
Okay, all right. So the patient's sense is, I feel fine, right? Their conclusion is, therefore I am fine. Now, one of the things that we know is that human beings use what are called schema to make sense of things. A common schema is if I feel okay, what?
Therefore, I am okay.
I am okay. And you know what, Kim? Generally speaking, that's true. Generally speaking, that's true. But you and I know that, for example, you can feel okay and have high blood pressure and be at risk because you can't feel that your blood pressure is elevated. So the patient's sense is, I feel okay. Their conclusion is, I am okay. What's their decision about behavior?
Medication is optional.
I'm not doing this, right? Because why would I need to? Now, remember I said that when people are ambivalent or resistant about behavior change, their sense-making is problematic because it's either operating with incomplete or inaccurate information. This patient's operating with incomplete information. The incomplete part is they don't know how they can feel okay and still be at risk. Now, so listening for that is what informs me about what I need to do as a healthcare professional. Now, it's really unfortunate that the typical response, and I've had the opportunity to listen to hundreds of hours of phone calls between patients and healthcare professionals de-identified for HIPAA. And the typical kind of responses you hear are, well, you can't feel when your blood pressure's up. And do you hear the comma stupid at the end of that sentence? And we cause patients to lose face. When patients lose face, they either discount the information that's about to be given, or they disregard it altogether. And we've got studies to support this. And so what we don't want to do ever is try to persuade patients to do something who are ambivalent or resistant because they're not ready, or convince them because they're not ready, or cause them to lose faith. And so our approach to MI, remember, now what I've got to be able to do is help the patient understand how they can feel okay and still be at risk without causing them to lose face. So when a patient now says, I don't understand why I need this medicine, I feel fine, the first thing I'm going to say is, so because you're feeling okay, you're really kind of wondering, why in the world do I need this medicine? And guess what the patient says? Right. And on top of the fact that the patient says right, they now know what about me? That I've listened to them and that I've not passed any judgment. And what I'm really doing is giving them the opportunity to say, am I correct about what I've just heard you say? Okay? So it does two things. It gives them an opportunity to say right, or it gives them an opportunity to say, no, it's not quite that, it's this. And that's important, because if you don't know what, you know the old expression, if you don't know where you're going, any road will take you there. So I have got to first know that I'm really nailing down how the patient's making sense. Now, the patient says right, and I now say, you know what, you raise a really good question. What does that say to them? I'm encouraging them to push back. Because a lot of times patients won't push back and they'll go home and they won't do it. And I want them to know that it's okay to push back. And then I'll say, would you mind if I shared some thoughts with you and you tell me what you think? Now, there's a lot of things going on there with a very simple statement. It's saying, I'd like to share some thoughts with you, but I also want to know what you think. And notice I don't say, I'd like to share some clinical information with you, which is not very conversational, and it puts me in the role of I'm the only expert in the room. So very conversationally, I say, would you mind if I share some thoughts with you? You tell me what you think. I've never had a patient say no. I've had patients say, you can share some thoughts, but I still may not take the medicine, in which case I say, you know, that's fine. I want you to know this really is your decision, because it is. We delude ourselves in thinking that just because we tell people to do something that they're now going to do it. So after I ask that question and they say, sure, I would then say, you know, high blood pressure is one of those conditions that really doesn't have any symptoms. And the first symptom is often a stroke or a heart attack. That, in other words, people's blood pressure can be elevated and they don't even feel it. And therefore, people stop taking their medicine or never start taking their medicine. And I would hate to see that happen to you, because you can actually reduce your blood pressure by the use of this medicine. And it would be really tragic if you didn't take the medicine and had a stroke or a heart attack because you felt okay. Where does this leave you now in terms of taking the medicine? Notice I don't say, therefore, you need to take the medicine. Because if I said that, a lot of patients might say, okay, even though they weren't convinced. Saying, where does this leave you now, allows the patient to have the opportunity to either say to me, wow, I never realized that, or come on, you're saying I can feel this good and still have the stroke or heart attack, in which case I can now say yes. And that's the dangerous thing about high blood pressure. What are your thoughts? So that's one example. That uses how the patient's making sense, all right? Here's another example. And I've been given permission to use this. Kroger is one of my clients. And they've had a number of their pharmacists go through my training. And when I put people through this e-learning training, they also get a minimum of one webinar with me to actually say, here are the things we're still confused about or struggling with. So I was having one of those conferences with Kroger, and this is what came up. Number of the pharmacists said, okay, this happens all the time. We got this patient, we'll call him Ed Jones. They call up Ed. Ed always is taking his blood pressure medicine for about 4 days a week. Supposed to take it every day, right? Mm. And they say, hey, Mr. Jones, we notice you're taking your medicine about 4 days a week. You having any problems on the other 3 days? And Mr. Jones says, no, I just take it 4 days a week. And they say, well, Mr. Jones, you really need to take it every day to get your blood pressure down, because you can't feel when your blood pressure's up. And he says, yeah, I know. I'll take it. Don't worry about it. A month later, they're calling him back, and he's still taking it 4 days a week. And they say, what are you supposed to do? And I say, what do you learn when you tell him you need to take it every day? And there was silence on the other end of the phone. And they said, what do you mean? I said, what do you learn when you tell him he needs to take it 7 days a week?
Nothing.
That's right. And besides the fact that he says, okay, I'll take it every time, right? And they said, but what are you supposed to do? And I said, if you remember, motivational interviewing is also built on Seligman's positive psychology. We have this tendency to focus on what the patient's not doing. The patient's taking it 4 days a week. Why? I said, what would happen if you said, hey, Mr. Jones, I notice you're taking your medicine 4 days a week. That's a great start in getting your blood pressure under control. What's made it important for you to take it on those 4 days? And they literally went, oh my gosh, I would have never thought to do that. And now, will you learn something? Something's made it important for this guy to take it 4 days a week. What is it? Mm-hmm. One patient might say, well, I took it 4 days a week and I felt fine, so I figured, why take it more, right? Another patient might say, if I take it more than that, I start getting these side effects. Another patient might say, I can't afford to take it more than 4 days a week. But now we know what's going on. If it's in the first case, then we can say, okay, so because you felt okay after 4 days, you thought, why do I really need to take it more? And again, we could say, great question. Would you mind if I share some thoughts with you? You tell me what you think. But in any case, we learn something. And we can also learn something about the patient's internal motivation. They might even say, well, I knew it was important to get my blood pressure down. I don't want to have a stroke or a heart attack. But I figured if I felt okay after 4, why take more? And from the patient's sense-making perspective, that's really reasonable. Right?
It could be from the patient's point of view.
That's right. From the patient's point of view, it absolutely is reasonable. Now, we know that's a dangerous strategy.
Yes.
But then it's our job to then be able to communicate this in a way that, again, doesn't cause the patient to lose face. And increases the probability that they'll actually hear what I have to say and make better decisions.
That's great. Those examples are great. Now, I know that you're talking about folks who have gone through your training and then they still have questions. And I love that you offer that webinar, that private coaching session, because that gives people an opportunity to write down their questions or scenarios, bring them to you and just get some input. And then you're giving them the words to use. I feel like that's so important to have the words to use. It's almost not like a script, but it's just another way of doing it that might work. And it's all about the patient, really. We're just trying to help the patient, and you're ultimately helping them help their patients. So that's great.
Yeah, and the e-learning actually has just tons of audio cases where they get to listen to healthcare professionals and patients doing it inappropriately and then using MI. And the really cool thing about the e-learning is they hear these two people talking and their words appear on the screen. So they can actually not only hear what they're saying, but see the words. I then come back, both for the inappropriate and the appropriate, and talk about where in the conversation did this go south. And we can actually light up the words on the screen, and people can see why this went south. On the other hand, when we do the MI example, we light up the words on the screen that allowed this to come to a resolution for improving health. Now, the webinars that I do, they get each group that does a group rate gets at least one complimentary webinar and more based upon the number of seats they buy. They can buy additional webinars if they want them, but that's up to them.
And when you say webinar, I call it private coaching. Are we talking about the same thing?
Well, we're talking about they're actually setting up a webcast where I can see them and they can see me and they can ask questions, or they can do what we're doing now by audio only, where I can talk to them as a group and they can talk to me and ask questions, and I can pose situations to them and help them resolve issues they're having.
Great. That's wonderful. Now, let me just ask you, since this is out there and anybody that's a healthcare practitioner or you were saying that you've got clinical psychologists can partake of this, what are barriers to them? What do you see as barriers to them actually enrolling in this e-learning course?
I don't think a barrier is financial, because it's pretty inexpensive. It's for individuals, it's $195 for 8 hours of continuing education credit, and we do have months where we have discounts and we announce them. And for groups, it's even less. And as I told you, for the schools, it's only $1,000 for a year. I think the biggest barrier is most people don't think they need 8 hours. And I think 8 hours is a minimum. Then, and apart from that, once they learn MI, then there are new barriers that we have to overcome once they've even learned it. For example, MI is patient-centered. And that means to be patient-centered means if you're my patient, your needs are far more important than mine. I'm here for you. You're not there for me. It's not your job. It's not your job to make me feel okay. It's my job to help you have health, to assist you in that. To be patient-centered means that I have to, and I'm going to get a little bit biological, I have to exist in the prefrontal cortex of my brain. Because the prefrontal, and we've identified that MI takes place in the prefrontal cortex, where complex decision-making takes place in high-level empathy. Now, let me give you an example of what happens when you're not in that part of your brain. I was precepting a pharmacy student, and a guy came in with a prescription for warfarin, and he put it on the counter and sat down next to it a large bottle of regular aspirin, not baby aspirin. Now, the pharmacy student did a great job, and first of all said to him, are you Robert Smith? And he said, yes. So she first identified that this was his prescription. And then she did the next thing, which was appropriate, is the aspirin for you? It's not for him. There may not be an issue. And he said this. He said, listen, little girl, I've had the lecture. Aspirin's the only thing that gives me relief from my back pain. So no, I'm not going to stop taking it. And no, I'm not going back to the doctor to have blood work done just so he can make money off of my health plan. She froze. She absolutely froze in her steps. And she is now in the limbic part of her brain. And the limbic part of your brain can only do one of three things. It can fight, it can flee, or it can freeze. And you cannot do MI in that part of your brain, because now you're no longer patient-centered, you're who-centered?
Me.
Correct. You're simply trying to survive. The way I put it to healthcare professionals is, as an example, if you're being chased by a bear, you don't look back and go, gosh, I bet he's hungry.
No.
You have no empathy for the bear. You cannot be bear-centered when you're trying to survive. And you cannot do MI in that part of your brain. And so when we were all done, I took over, by the way, and I asked her when we were done, did you feel physically threatened? And she said, no. And I said, why do you think you froze? And by the way, we call these oh crap moments. in our book and in our e-learning. And we talk about them and what you can do to stay out of the limbic part of your brain more often. And she said she literally had an, oh my God, I don't know what to do. Basically, I don't know how to save him. And it's this, and that's what put her in that part of her brain. I never feel like it's my job to save my patients. That's their job. My job is to love them. My job is to give them good information and to help them make better decisions. And so here's what I did. And see, once you get that, what's available to you is MI. And so I looked at him, what's his sense? So I listened for his sense making. He had two important things he was telling me. One, my sense is aspirin's the only thing that gives me relief from my back pain. His second sense was, I don't trust the reason my healthcare professional wants to do blood work. Did you hear that also?
Yes.
So here's what I said, because MI is about, our approach is about sense making, listening for and addressing the sense making. So here's what I said. You've been getting a lot of relief from your back pain, and you don't want anybody taking that away from you. And I want you to know, I don't want to take your pain relief away from you. And then I said, it also sounds like you've got some serious doubts about what your doctor's motives are in having blood work done. And he looked at me and he said two words, damn right. Now, what he's saying when he said that to me was, you got it. I am now in a position to influence change in a positive way. And I did it by not looking at him and saying, are you nuts? You don't need to be taking aspirin with warfarin. I did it by showing him I understood how he saw the world. Now, in motivational interviewing, if you've noticed in some of the examples I've been given, we ask permission. We say things like, would you mind if I shared some thoughts? There is an exception to that. I don't ask permission when I fear that the patient may say no, and it puts them at risk if I withhold the information. This is one of those examples. So after he said, damn right, I did not ask permission. I simply said, here's what my concern is. I really want to help you get relief from your back pain, and I want to talk to you about that. I don't want to take your pain relief away from you. But here's what worries me. Aspirin can actually make your warfarin work better than it should, and actually cause you now to go from having a blood clot to actually hemorrhaging. And you could die from that. And your doctor wants you to monitor so that he can adjust your dose if need be. Now, it's possible to take your warfarin with aspirin, but only if you're monitored. And even then, it's somewhat dangerous. I'd like to act as your advocate. Call your doctor, and before I do that, talk to you about some alternatives to aspirin that you can use. And I also like to talk about what you've done so far for physical therapy so that you can more safely get pain relief and still use your warfarin. Would you be willing to have me do that? And he said, you think this is serious? And I said, I really do. That would have never happened if I looked at him and said, you don't need to be taking aspirin with your warfarin. And that's the power of MI. It changes the dynamic. And notice, I didn't tell him what he had to do. I said, here's some things to think about. And again, she also learned, the student also learned, that what was keeping her from doing MI was not him. It was her need to try to fix something. And so in our book and in our e-learning program, we have an entire chapter and module focused on what we call MI and social threat, the brain and social threat. Because you can have physical threat, but you could also have social threat. And healthcare professionals experience social threat all the time. They hear it when patients say, who have diabetes, I'll take the medicine, don't expect me to do anything else. And they're sitting there going, well, that's not enough. And then the patient now has social threat. and nobody's getting anywhere. Rather than taking the medicine is really an important step in getting your diabetes under control. I'm really glad to hear that you've made that commitment. Would you mind if I talk to you a little bit more about what might help your medicine work well? And then they say, you can talk about it, but I still probably won't do it. And I'll say, fair enough, but they've given me permission.
That's a great example of a barrier that I would not have anticipated to using MI, even when you know how to use it. Freezing. Who would have thought?
And there is one other barrier.
Yeah, I was just going to ask, is there anything else you can think of? That was a great story. What else you got?
Yeah, the talk I was actually going to do at APHA was about self-deception and objectification. Women, as you know, have been objectified in our culture for eons. Mm-hmm. People of different racial origins have been objectified in our culture also. Whenever we objectify a human being, we reduce a person to an object. And here's a really interesting question. And this is part of what I was going to be talking about in my seminar at APHA. If people are always people, even when they're behaving badly, if we are always people, even when we're behaving badly, for me to see you as an object means that I must become blind to the reality of Kim. Does that make sense to you?
Can you explain a little bit more about what you're getting into?
Yeah, what I mean is you're a person. Mm-hmm. You're always a person.
That's right.
For me to see you as an it means I must become blind to you being a person.
Okay, I gotcha.
And the blindness exists in me. So the question is, what causes me to become blind? And it's not you, by the way. And that's what my workshop was about. And the point is that to be patient-centered, to do MI, you also must not reduce a person to an object. Because if you reduce a person to an object, you will also feel justified in providing less care or in mistreating that person. I hear pharmacists and healthcare professionals all the time say about patients, they're difficult. They won't listen to what I'm telling them. That human being is no longer a person to them. They're just some difficult thing. And they feel justified in not treating them with the same dignity and respect they feel like they should give other patients. That's a dangerous place to be in healthcare. And so my workshop at APHA was about how and why do we objectify? How do we keep ourselves from objectifying far more often? Because it's dangerous. If you'd like a little bit more concrete example, I'd be glad to do it. Depends on
absolutely.
time.
You just blew my mind. Oh, we've got time. Let's hear it.
Okay. Here's a common example, common experience that we all us humans have. We're driving down the street, and we got shopping areas on either side of the street. So 4-lane road, medium strip, shopping on right side, shopping on the left side. We're in the right-hand lane, driving down the street, and we see somebody down the street in the shopping center who's going to be entering the road, right? And we think to ourselves, surely they're not going to pull out. Surely they must see me, right? And then they pull out. And if we do not honk our horn and slam on our brakes, we would hit them.
Yep.
Okay? Now, I ask people all the time, what are some of the common things that we do when we approach them? What would you guess, Kim, are some of the things that we do as we get closer after they've cut us off?
Slam on your brakes.
Slam on our brakes.
Yeah, start protecting myself.
Okay. And
I don't want to crash.
That's right. So that would be protective. We also honk our horn?
Absolutely.
And more than likely, we will lay on our horn, not just honk our horn. And we will also, if we pull up next to them, what might we do?
Smile and wave.
Really? I think the more common experience is we will yell at them. We might even gesture. with our hand. Do you agree with me?
Yes.
So, and here's what's interesting. Not only will we do that, yell at them, honk our horn, gestures, showing them that we're angry. How could you do something like this, you idiot? That kind of stuff, right? We will also go home and tell people about this and tell them what we did, right? And that we laid on our horn, and they'll say, good for you.
See, I'm a motorcycle rider, and I got to tell you, people pull out in front of me all the time. It's dangerous, and you got to have a healthy level of paranoia about getting hit all the time. I think it's made me a better automobile driver. But yeah, what you're talking about, it happens too often.
All the time. Now, here's what's interesting. Realize in that moment, we have now reduced that person to an idiot or something like that, right?
Especially in our story afterwards, yeah.
Yes, okay, that's correct. Well, in the moment we even did. And I'll tell you why I know that. Because if you pulled up next to them after you've been honking your horn and you're now about ready to, and you're yelling at them, and you now see they are your priest, minister, rabbi, or best friend. Now, how are we feeling?
Differently.
Embarrassed? Want to hide under the dash? Right?
Yeah. Yep.
But in our story, when we told the other person, how did we feel about our gestures and anger and honking our horn? Justified. And now we feel embarrassed, which says, where does the problem lie with us? And so the real question is, what was it that caused us to reduce this human being to an object? Because if you think about it, we've all made mistakes driving. We've all cut somebody off. So surely we know that the vast majority of people are not doing this on purpose. It's just a mistake. So the question is, why do we objectify?
Probably because we have a plan and somebody interrupts it.
I think it's bigger and broader than that.
All right,
okay?
Let's hear it.
But well, I'm just saying this would take a long time, and it's the subject of 2 hours of a workshop.
Yes.
But here's the general principle. Whenever we betray what we know to be the right thing to do in regard to another person, and we do not acknowledge the betrayal, we will justify ourselves, objectify, and become self-deceived. The right thing to do in that situation would have been slam on our brakes to protect ourselves, to honk our horn to let the person know that they've pulled out and gotten in the way. And that should have been about it. Because the fact of the matter is, even if we had somewhere to go, it doesn't change that. In other words, it is the anger that comes directly from our betrayal of what we should have done for another human being. And we can get into a long discussion about that, but that's the subject of that 2-hour workshop. But whenever we objectify, we cannot be other-centered. We cannot be.
And it prevents us from using motivational interviewing to the best of its ability, right?
Absolutely.
Yes.
And people who do MI, when they really get it at a deep level, never say things like difficult patient. There are difficult situations. The guy with the warfarin, that's a difficult situation. But he's not difficult because he wants pain relief. And by the way, he's not difficult because he mistrusted his doctor. What we found out afterwards, which is not surprising, is his doctor admonished him for wanting to use aspirin rather than understanding. So he then distrusted his doctor's reason for wanting blood work done. Remember I said earlier, if we cause people to lose face, they'll either discount or disregard valid information. And that's what happened. And so, these principles are powerful and they work once we get them at a deep level.
Well, I love that this is available to all pharmacists and that you teach it and it's available by e-learning. This is a great time to be doing your continuing education by distance, getting onto the Purdue website. I will put that website, by the way, in the show notes so any of my listeners can find it. Yeah, thank you for sharing that. And at this time, I wanted to know, is there anything else that you'd like to add to what we covered today? Anything else you want to share with our listeners today?
The only thing I would add, which I kind of alluded to earlier, is that if you're going to learn MI, please invest the time to really learn it. Again, I've watched organizations and schools of pharmacy and medicine do 2-hour programs on MI. It's not enough, and oftentimes people will leave and then go try to do it. And they don't know how to do it. And they get frustrated. And they blame MI. And they say, see, that stuff doesn't work. And the real problem is they've not yet learned it in a significant enough way for it to work. When MI is used properly, it is unbelievably powerful. We did a major study with Biogen years ago concerning the drug Adherence for MS. And we did a clinical controlled trial. And we published it and won a national research award too, where what we did is we randomly put patients into a treatment group and a control group. And the only difference between the two groups was motivational interviewing interventions. Biogen had a 13% dropout rate on the drug Adherence when we did this study. After 4 months of motivational interviewing intervention, we reduced the dropout rate to 1.2%. That was a projected savings to Biogen and help for patients of $93 million.
Wow.
Yeah, and it was because we used MI to help the patients in the treatment group. The control group got whatever they were getting before, and as you would guess, nothing much changed. So when MI is done right, it is really powerful. So invest some time. And I'm not saying that because I got an 8-hour e-learning. Miller and Rolnick, the people who developed MI, will tell you need a minimum of 8 to 16 hours of training and application to get really good at MI.
And then use it daily on patients, and that can only help you hone that craft, right?
That's right. That's correct. That's correct.
Very good. Anything else you'd like to share before we wrap this up?
I think that's it. And other than if you're going to be around, hopefully APHA will be around next year. I've already been invited to do my session next year on self-deception and objectification. I hope that a lot of you will show up. We decided not to do it as an online program because so much of what I do with the self-deception involves group participation, and it just doesn't work online. There are some things that don't work online.
That's all right. But your e-learning course is definitely available, and I will definitely put it in the show notes for my listeners to check out.
Great. And I am the on-screen coach on the e-learning program.
How cool is that?
Yeah.
All right. Well, thank you very much, Dr. Bruce Berger, for being with me here today on the Pharmacist Voice podcast. Take care.
My pleasure. My pleasure. Thanks.
Thank you for listening to episode 13 of the Pharmacist Voice podcast. Please visit thepharmacistvoice.com to subscribe and read the show notes. That's thepharmacist with an S, voice.com.